You've completed 5 years of hormone therapy for breast cancer. You're ready to move on, but your doctor says, let's keep going. Why? Is it worth the side effects? And how can a genomic test help you decide if you really need more treatment? Today, we're unpacking the science behind extended endocrine therapy and what it means for your future. For women with hormone receptor-positive breast cancer, endocrine therapy using medications like tamoxifen or aromatase inhibitors has been a key part of treatment. It works by blocking or lowering estrogen, cutting off the fuel supply to cancer cells. Traditionally, the standard was 5 years of therapy, but we now know that's just the beginning of the conversation. We'll explain why some patients need longer treatments, how clinical trials shaped our understanding, and how powerful genomic tests like the Breast Cancer Index and others are helping personalized care. Endocrine therapy reduces the risk of cancer coming back. Tamoxifen is often used in premenopausal women, while aromatase inhibitors or AIs are preferred after menopause. ASCO and NCCN recommend at least 5 years for early-stage hormone receptor-positive breast cancer. That cuts the recurrence rates by about 50% and breast cancer deaths by 1/3. But many recurrences happen after treatment ends, sometimes 10 or even 15 years later. So, stopping tamoxifen after 5 years is enough? Let's look at the research. The ATLAS trial followed 12,000 women who had received 5 years of tamoxifen and then were randomized to continue for an additional 5 years for a total of 10 years. And there was a 25% reduction in the risk of recurrence for the patients who took the tamoxifen for 10 years compared to 5 years. Similarly, the aTTom trial involved approximately 7,000 women, confirmed the same findings. 10 years of tamoxifen reduced late recurrences and improved survival. Importantly, these benefits were most significant for women with node-positive disease, meaning cancer spread to the lymph nodes. Then there is the MA17 trial, which looked at switching to an AI after 5 years of tamoxifen. Women who took letrozole for 5 more years had better disease-free survival and lower recurrence rates, especially if their initial tumors were larger or involved the lymph nodes. More recently, the ABCSG trial in Austria showed that extending AI therapy beyond 5 years might not help all patients. In fact, the best balance of benefit and side effects appeared at around 7.5 years, not 10. Based on these results, the NCCN guidelines have now in 2025 recommend that women receive 7.5 years of an aromatase inhibitor. AIs can cause joint pain, hot flashes, myalgias, lower quality of sleep, and mood changes. We need to consider the risk of recurrence and the side effects. Not all hormone receptor-positive breast cancers have the same risk. There are some genomic tests where looking at some specific genes in the tumors can help us decide what's the prognosis. The Breast Cancer Index, or BCI, is a test specifically designed to answer one question: will extended hormone therapy help you? It gives a prognostic score, a risk of recurrence after 5 years, and a predictive score, which is the likelihood of benefit from hormone therapy. If both scores are low, stopping at 5 years is usually safe. The Oncotype DX, while helps decide in which patients may need chemotherapy after diagnosis, may not be as helpful in answering this question. It is not validated to predict benefit from extended therapy like BCI is. Prosigna, another test that measures 50 genes, or PAN50, provides the risk of recurrence and assigns a type of breast cancer subtype. So for patients who have very low risk of recurrence and a luminal subtype of cancer, those patients have a very low risk of recurrence with only 5 years of tamoxifen. Another test is the MammaPrint, which looks at 70 genes and categorize patients on their risk of recurrence, whether it's high or low. It has some use in predicting late recurrence, but its role in guiding extended therapy is less established than BCI. Among these, the BCI test remains the only test currently validated to guide decisions on whether extended endocrine therapy will provide actual benefit. Science gives us the tools, but you make the choices. If you're finishing 5 years of treatment, here's what your care team could consider. tumor features like size, grade, lymph node involvement, side effects and your tolerance so far, menopausal status, and results from genomic tests like BCI. Your personal preferences and lifestyle are also very important. This is called shared decision-making, where your voice matters just as much as the data. Thinking about 5 more years of treatment can be emotionally draining. Many patients feel uncertainty, fear, or frustration. That's normal. Survivorship care isn't just about preventing recurrence, it's about living well now. Ask your team about support resources like counseling or mental health care, physical therapy for joint pain, bone density monitoring, survivorship clinics, or peer support groups. You're not alone in this journey, and you shouldn't have to navigate it without help. If you or a loved one is approaching the 5-year mark in endocrine therapy, talk to your doctor about genomic testing, especially BCI in 2025. Share this video with someone who might be facing the same decision. 5 years ago, finishing hormone therapy was the goal. Now, science gives you more options, tailored to your exact risks and needs. Whether you choose to stop or continue, you're not guessing. You're choosing powerfully with evidence, support, and a plan. And that's something worth celebrating. Thank you.